my talk is about casting in early onset scoliosis. Maybe it's an old issue, but it's already being revisited again and being validated. So I have nothing to disclose regarding this talk. So Dr. Nariman elaborated very nicely about the early onset scoliosis and the classification, the CEOS classification, which matches the Linky classification in the AIS. And it's very helpful. But what about the one of the data that help us as regarding the progression? The RVAD, which is the rib vertebral angle difference between the rib on one side and the apical side, and the difference, if it's less than 20, so it's going not to progress. If more than 20, it's going to progress. And to classify the early onset as regarding the rib phase, so in the lower picture here, down there, if the rib is overlapped, that means that phase one. If there is an overlap, so this is going to progress. So, and in general, the treatment algorithm as regarding the curve is less than 20 RVAD, or the curve is less than 30 observation. Bracing sometimes can be helpful, although the literature sometimes indicates it's not effective. Casting with the elongation, the EDF, the elongation, derotation, flexion casting, or the wrestler casting, it indicated in cob angle more than 30 degrees. The RVAD is more than 20. The rib phase is 2, or there is curve progression as regarding with the CEOS classification. And for sure, the surgical intervention. We all know that when we are starting to revisit or visit the spine and early in life, the complication rate will be more or higher. So the casting is a very old maneuver, have been used by Hippocrates and revisited as well with Dr. Risser with the bending cast. But re-innovated by Cattrall and revived by Miss Meta. And as you can recognize, she by herself, she had a scoliosis as well, and she's dedicated to the non-surgical treatment of scoliosis. So what is the difference between the Risser cast and the Metacast? The Risser cast is the lateral force bending, focusing on the frontal cup angle, and it only doesn't address the rotation, and sometimes it's well recognized to deform the ribs. On the other side, the Metacast is a twist and shift rather than push and bend, and primarily it addressed the curve through the correction of the rotation. So casting by itself, coming from the orthopedic world, so we use it in the Ponseti casting in the club feet, and we use the collagen. So the collagen in the bone, type 1, or the cartilage or in the ligaments in type 2, they have two properties, the creep and stress relaxation. So the creep, when you load it, it increases in the length, and the stress relaxation is the decreasing in the tendency of this material to return to its original shape when unloaded. So that's the essence of the doing of the casting, either in the club feet, in the deformity correction, either in the spine or the lower limb. So the EDF casting, or the elongation, the derotation flexion casting by Meta, is an elongation. It's a longitudinal force from the pelvis and the occipital traction, in which the weight ranging from 50 to 70% of the total weight. With the derotation, this maneuver that you are pushing on the rib hump from one side and derotating the shoulder, the same technique that you are doing in the derotation in the real spine scoliosis surgery, and with the flexion to correct the scoliosis. So Meta and her paper, it included the 136 children, 10 of them, 100 of them were idiopathic. From them, she cured, or claimed that she cured 98 of those patients. Cure meaning that it's a different target when we are treating the scoliosis. But in 48, she claimed that she reduced but not reserved the deformity. Either way, she documented that 35 went to the posterior spinal fusion. The casting style can be different. You can include the shoulder strap, yes or no. It doesn't make in the literature a difference, but some advocated it. But there's a lot of literature that casting can delay the surgery 2 years, even in congenital scoliosis. So a lot of literature at the bottom line, they recommend that, or they title that the cure can be possible. So cure is another item that we are speaking about in scoliosis. Sometimes it's palliation. Many of the patients only to be braced and only to have one single stage of surgery rather than doing multiple surgeries. Or sometimes it progresses, but even going with progression, we can consider it a win because the larger curve is less larger than it should be if left alone. So the downside of everything, there's downside of casting as well. The going back and forth for the anesthesia and exposure, complication from the rash, the rib deformities, some reports on the DVT or brachial plexus injury as well, and avoiding kids from playing and their daily activity. So the accepted protocol with the casting that you start the cast at the age of 1 year when you start to walk. And mostly you change the cast every 2 months in 2 years, less than 2 years, every 3 months, if there are 3 years, 4 months, if there are 4. So when you are getting older, the rate of changing the cast is less. And you're doing the MRI before doing this manipulation and continue to the clinically improved less than 10 degrees and follow up with a brace. The Metaframe. So the Metaframe is a specific table with this, all those ratchets and the mirror and the frames that designed, and now the Noil frame as well. And this picture in the down here, the amount of derotation that we are pushing on the rib on one side to derotate the rib cage and the spine. And the cast should be including the whole trunk, and with the posterior window on the concave side, don't cross the midline and the back. And to do this 8-shaped window with this 8 to avoid hitting the floating ribs, so to avoid it coming out of the cast. And so the question is, we don't have it in our country here, and that's why. So this is like an Egyptian style of the table. So this is like an old stretcher. You can appreciate the rust on the edge of the table. So this is like a gauze stretched with a tape over superimposed on it, and with the gauze as well, tape on the sides, and you reinforce it with a tape as well, and use the pillow for the flexion. And you can teach your team how to do it. So at the lower part here, this is like the ACE wrap or the crib bandage. I put it on the iliac crest on both sides to be sure that you are pushing pull both pelvis at the same time with the halter traction, and be aware that you are putting something inside the, as we all know, like the airway to avoid biting the tube, and support the arms. And you have to have a team that dedicated, and you have to have like a checklist for what. This is free because if you want to go through, so it's very easy to be done. So the Mata, you can add like the mirror at the back, so you can add it to this frame, and the image can go because it's image guided as well. So a couple of examples, and want to emphasize about this mold on the pelvis, because a lot of time when if you don't use the shoulder straps, maybe the cast will fall down. So the mold on the pelvic crest is very important as well. In early onset scoliosis, yes, you can use it in congenital, maybe to buy time, and even in some new muscular kids that you don't know what to start with, just to give you sometimes it can help. Maybe the family, you should educate the family that it's buying time rather than the definitive management. Sometimes it can help or make the surgery more easier. So my take home is the EDF cast can be use the property of the collagen of the creep and stress relaxation allowed to cure, which is a new term in the scoliosis world. And even though it can buy more time and educate the family about the risk and benefit. So allow me for this few seconds to ask you to join us in the AO Spine, and hopefully that we'll meet in the future in our activities to learn from each other and to practice, like in discussing with the cases. It's mostly this community is based on clinical cases and discussion rather than doing lectures, and to do research to gather information and connect with the colleagues that we all learn from each other. Oh, thank you very much. And this is one of our kids in our team in Mansoura University. I appreciate all our teams and Dr. Ihab Yusuf, Dr. Mohammed Sayyid, Dr. Ahmed Badia, for this one of the attraction sets that we did it in our unit as well. So thank you very much.